Hi guys, welcome back. So for today's video, we are going to talk about reflexes. So this is still part of the neurologic examination. So before we begin, I want to apologize because it's going to be quite loud outside. We're next to a pub, so I'm gonna actually try get close to you guys so you can hear me. So as I said, today we're going to talk about reflexes, and I think this is going to be part 4 of the neurologic examination. So recall that we have done the examination of the 12 cranial nerves, we've done the examination of the sensory system, we've done the examination of the motor system. So this is like the last part of the neurologic examination. So for today's video, we're going to discuss reflexes like the muscle stretch reflex or the deep tendon reflexes. We'll talk about cutaneous stimulation reflexes and other miscellaneous stuff for the neurologic examination. So the remaining ones that we have to do. So for instance, asterixis, we need to test for, we need to do the straight leg raise test if we suspect lumbosacral radiculopathy. What else? We'll talk about like the winging of the scapula. So this is a test that you need to do, or this is indicated if you suspect muscular dystrophy or like injury to the long thoracic nerve. So we'll discuss quite a bit today. Let's begin our discussion with deep tendon reflexes, also known as muscle stretch reflexes. So these are involuntary monosynaptic cord reflexes that arise from like the stimulation of partially stretched muscle fibers. So we use like a grading system to grade, the strength. I don't know if that's the right word, but we use this grading system to rate the reflexes. The deep tendon reflex grading system that we use basically has a range of 0 to 4 plus. So it goes 0, 1 plus, 2 plus, 3 plus, 4 plus. So 0 means that there is complete absence of movement. So we don't see any reflexes at all. And 1 plus means diminished reflex. So like less than normal. 2 plus is the average or the normal reflex. 3 plus is brisker than average, and 4 plus is very brisk, but the criteria says that it has to have clonus. So clonus is just like the involuntary rhythmic oscillations between flexion and extension. So this is again the deep tendon reflex grading system. Hyperactive reflexes are seen in lesions, in CNS lesions of the descending corticospinal tract. So if you suspect lesions as such, you need to look for associated symptoms of the upper motor neuron disease like weakness and spasticity. If the reflexes are hypoactive, which means like lower than normal, this is usually seen in CNS lesions of the spinal nerve roots, and you need to look for associated symptoms of lower motor neuron disease like weakness, atrophy, and fasciculations. Now let's go over some of the techniques that we can use for the examination of the reflexes. So firstly, we need to encourage the patient to relax while we're performing these examinations. Secondly, because the reflex is partly dependent on like the amount of force that we use to strike the tendon, this means that we need to use enough force to elicit or provoke the reflex response. And thirdly, if the patient's reflexes are symmetrically diminished, we can use the reinforcement technique. So this basically involves isometric contraction of the muscles for up to 10 seconds. So for instance, if you want to reinforce arm reflexes, you can ask the patient to clench their teeth or squeeze their knees together. And if you want to reinforce leg reflexes, what you can do is ask the patient to interlock their fingers and pull one hand against the other before you strike the patellar tendon or the Achilles tendon to provoke the patellar tendon response or the Achilles tendon response. So now let's talk about the actual deep tendon reflexes that we need to test for during the examination. So firstly, we need to test for the biceps reflex or the biceps tendon reflex. So to do this, we need to have the patient's arm slightly flexed at the elbow and the forearm pronated. I don't know if you can see. I'll move back. And we place our thumb or like our index finger on the biceps tendon, and we hit the thumb or the finger briskly with a reflex hammer. And normally what we should see is the flexion. So we need to see the flexion at the elbow, and we need to feel for the biceps muscle contraction. So the second one is the triceps tendon reflex. So again, with the arm slightly flexed at the elbow, we need to strike the triceps tendon just above the elbow with a reflex hammer briskly. And what we need to see is the extension at the elbow and the contraction, and feel for the contraction of the triceps muscle. And then the last one for the arms is the
brachioradialis.
So for this, what we need to do is have the patient's arm like on their lap, so you won't see. So I'm just gonna elevate my arm so you can see. So you have to have it resting on on the patient's lap, on their lap. And what you need to do is, so the forearm is partly pronated, so not completely, yeah? And you need to strike the radius, so just 1 or 2 inches below the wrist. So you strike, and what you need to see is the supination and the flexion of the forearm. Moving on to the reflexes of the lower limbs, so we need to test for 2 mainly. So we need to test for the patellar reflex. So what we need to do is ask the patient to sit down with their knees flexed, and we strike the patellar tendon briskly with a reflex hammer. So the patellar tendon is just below the patella or the kneecap. And what we need to look for is the contraction of the quads, which means the extension of the knee, okay? And the next one is the Achilles tendon reflex. So we can do this sitting down as well, so with the patient sitting down. So what we need to do is to dorsiflex. So again, sitting down, the knee is flexed. We need to dorsiflex at the ankle, and then we strike the Achilles tendon briskly with a reflex hammer. And what we need to observe normally is the plantar flexion of the foot. And we need to also note down the speed of relaxation. We need to note down the speed of the relaxation phase, because in certain diseases like hypothyroidism, the relaxation phase is actually slowed. Also, we can test for the Achilles tendon reflex when the patient is lying down, so lying in a supine position. So what we need to do if the patient is lying down is to flex at the hip and the knee, and externally rotate the leg so that the lower leg is resting on the opposite shin. And then again, it's the same principle. We dorsiflex at the foot, and we have to briskly strike the Achilles tendon, and we need to look for the plantar flexion of the foot. And again, we need to note down the duration or the speed of the relaxation phase. If the knee and the ankle reflexes are hyperactive, we need to test for ankle clonus. So recall that clonus is just the involuntary rhythmic oscillations between flexion and extension. So in this case, ankle clonus means the rhythmic involuntary oscillations between dorsiflexion and plantar flexion. So to test for ankle clonus, what we need to do is we need to just imagine this is the foot and that's the ankle. So what we need to do is we need to dorsiflex and plantar flex the foot a few times, and we need to dorsiflex sharply and maintain that dorsiflexion and look for the rhythmic oscillations between dorsiflexion and plantar flexion of the foot. So normally we wouldn't see this. We wouldn't see any clonus. We may see a few clonic beats if the patient is very tensed or if the patient just had exercise, but normally we should not see any clonus. After the assessment of deep tendon reflexes, we need to assess cutaneous stimulation reflexes. So there are two mainly. So we have the abdominal reflex and the plantar reflex. So for abdominal reflex, what we need to do is we need to stroke each side of the abdomen, and basically we need to look for the contraction of the abdominal muscles. So that is the normal response. And for plantar reflex, let me just show you. What we need to do is we need to stroke the lateral aspect of the foot using a key, or like the handle of a reflex hammer. And what we need to do is stroke the lateral aspect of the foot from the heel to the ball of the foot, like this, curving medially across the ball of the foot. Okay, so again, it's like this. And the normal response is the downgoing of the big toe, or plantar flexion, and the abnormal response is the upgoing of the big toe, or the dorsiflexion of the foot. And the dorsiflexion of the foot is called the positive Babinski response. Now let's talk about meningeal signs, which are some of the signs that you could test for if you suspect any meningeal inflammation from meningitis or subarachnoid hemorrhage, for example. So we have two tests. So we can do the Brudzinski's sign or the Koenig's sign. So let's first discuss the Brudzinski's sign. So before you perform this test, you need to ensure that the patient doesn't have any cervical vertebrae problems or any injuries to the cervical spinal cord. So for this test, what you need to do is have the patient lying supine on an examination bed, and you place both hands behind the patient's neck, behind the patient's head, and you flex the neck and try to get the chin as close to the chest as possible. So it's gonna look like this. Yeah? So normally what you should see is that there shouldn't be any pain or any resistance when you perform this neck flexion, this movement. And if there is pain and resistance to the movement, then this is a positive Brudzinski's sign for meningeal inflammation. Also, you need to look at their hips and the knee. So during neck flexion, what you need to see normally is that the hip and the knee should remain fully extended and fully relaxed on the examination bed. If their hips and knee flex during neck flexion, then this is again a positive Brudzinski's sign. Okay, so moving on to Koenig's sign. So Koenig's sign, the patient has to be lying supine on an examination bed. You flex the leg at the hip at the knee, and you kind of straighten the leg by straightening the knee, so by extending the knee. And normally there shouldn't be any pain, but discomfort behind the knee during the full extension of the knee is common, but there shouldn't be any pain or any resistance to this movement. So if there's pain and resistance to this movement when you're straightening that knee, this is a positive Koenig's sign. Another important test that we need to be able to perform is the straight leg raise test. So this is indicated if the patient is having lower back pain that radiates down their thighs and their legs. So this is actually a test for lumbosacral radiculopathy, or basically radiculopathy just means pinched nerve, and lumbosacral indicates pinched nerve in the lumbosacral region. So lower back pain that radiates down the thighs and the legs is commonly known as sciatica. So to perform this test, the patient has to be lying supine on an examination bed, and we need to raise their relaxed straight leg, obviously up, and we need to dorsiflex at the foot to about 60 degrees. And we need to ask the patient to let us know when the symptoms occur, i.e. pain. So positive straight leg raise test means that the patient will feel radicular pain or radiating pain down into their legs. And this happens due to the compression of the spinal nerve root, which causes, that painful radiculopathy. If the straight leg raise test is positive, then we need to examine the sensory and the motor functions as well as the reflexes at the lumbosacral region, because the radiculopathy or the pinched nerve may have associated symptoms such as muscle weakness and dermatomosensory loss. And usually the most common cause of radiculopathy at the lumbosacral region is herniated discs. Another test that we need to be able to perform is asterixis. So asterixis is also called as the flapping tremor, which would make sense in a bit. So asterixis can be observed in patients with hepatic encephalopathy, which basically means that the brain function is impaired due to the fact that the liver is damaged, and therefore the blood is not being cleared of certain toxins, and this damages the brain. So to perform this test, what we need to do is ask the patient to extend both of their arms right in front of them and cock the wrists back. So let me just show you. I'm not sure if I can do. So again, extend both arms right in front of them, cock the wrist back as if like they're stopping the traffic, And asterixis basically means that you would see tremors, yeah? So this can happen in one hand or both hands. And finally, we need to test for the winging of the scapula. So this test is indicated if the shoulder muscles look weak or atrophied. For instance, in the case of muscular dystrophy or injury to the long thoracic nerve. So to do this test, what we need to do is ask the patient to extend both arms in front of them and push against your hand or push against the wall. And you need to look for the winging of the scapula. So winging of the scapula can be defined as the medial border of the scapula jutting backwards as they push against the wall, okay? Just one thing to note though, like in very thin and very slim normal individuals, their scapulae may look winged even if the musculature is intact.